Bill, you may be on mute.
Let's try that again. Sorry. Apologize. Good morning again. Thank you, everyone, for joining us during this tumultuous time in our country's history. This is also a record attendance for BPC this morning. I'm Bill Hoagland, Senior Vice President here with the Bipartisan Policy Center, and I have the pleasure of working with our health team led by Marilyn Serapini, Catherine Hayes, and Dr. Anand Parekh. Like so many of you over the last 3 months, we at the center have been adjusting to this new way of conducting business and events through video chat and other technologies. And I think if there's just any silver lining at all in this terrible virus, it has forced us all to learn how to better use this technology. And certainly appropriate to the discussion today, it has laser focused us on the use of telemedicine for diagnosing, delivery, and treatment of healthcare. Obviously, telemedicine was a tool available prior to COVID-19, but recent statistics from Fair Health, an independent firm that tracks claims, has found a dramatic increase in telehealth claims filed over the last year, from less than 0.2% of claims filed last year to 7.5% claims just recently. A small base, but a 4,000% increase in participation. It is my impression that telemedicine has also gained greater acceptance by both practitioners and patients, and I think will only grow after this pandemic passes. In part, this growth is due to the relaxation of various telehealth regulations in the CARES legislation, which I'm sure one of our panelists, Jim Parker, the Senior Advisor to Secretary Azar, will want to address. I look forward to the discussion from the experts we have gathered today and moderated by my last boss on Capitol Hill, former United States Senator and Majority Leader, Dr. Bill Frist. Senator Dr. Bill Frist needs no introduction. An accomplished heart and lung transplant surgeon. Also, his legislative achievements during his time in Congress are particularly relevant today as he was the leader in passage of PAPA, the Pandemic and All Hazards Preparedness Act in 2006. He now is he continues to influence and connect with leaders throughout the country and the world, and he's an innovator and has a very popular Second Opinion podcast that you should check out. Senator Frist, along with one of our other panelists today, Dr. Jennifer McKay, were also members of a task force that we established a couple of years ago looking into rural health. And we just issued the final report on that, confronting rural health care, just a couple of months ago. Now, a couple of quick housekeeping items before we begin. All of you who are attending can ask questions through the Q&A button, but given we have well over 600, maybe 900 persons registered for this event, unfortunately, of course, we will not be able to answer all your questions, but we'll try to get to as many as possible within the hour. Finally, note that attendees cannot use that chat function to talk with one another, but you will find on that chat our recent task force that I just mentioned report, along with other material that we put out recently as it relates to the rural hospital financial struggles that they're going through as a result of COVID-19. Before we begin, let me introduce Walter Panziger, trustee of the Helmsley Charitable Trust. Walter has a long history working to improve the health and well-being of persons, not only in rural and frontier areas of the U.S., but also around the world. We are thankful for the support at BPC from the Trust, and also we share that same passion that he does for bettering the health of persons regardless of their geographic location. And telemedicine, we believe, can be a essential part of that. So without further ado, let me turn it over to Walter.
Well, thank you very much. I want to first of all thank the panelists for giving up their time to be here today. I'd like to thank the task force for their extremely hard work and great work to get things done and really dive into the problems of rural healthcare. And once again, thank everybody for attending this morning. This is really great to see 600 people, 600 to 900 people on this podcast. This got to be a new record for BPC. Little bit about the Helmsley Charitable Trust. It is my belief that your zip code should not dictate how your healthcare outcomes are. It doesn't matter if you live in the big cities like New York City or Las Vegas or somewhere in a small rural town. Your access to healthcare and quality healthcare should be equal. And that's what we aim to do at the Helmsley Charitable Trust. The Helmsley Charitable Trust Rural Healthcare Program started about 10 years ago. And in those 10 years, we have granted over $400 million in 7 upper Midwestern states of North Dakota, South Dakota, Nebraska, Wyoming, Montana, and Minnesota. Of that $400 million, we committed over $100 million to the expansion of telehealth care services throughout various actors and hospitals in those regions. With BPC, we knew that there were barriers to telemedicine and that needed to involve real change. And as many of you all know, as a foundation, we are prohibited from lobbying. So what the Helmsley Charitable Trust did was fund BPC's Rural Healthcare Task Force to do a deep dive and to really dig in and determine all the challenges to rural healthcare. We are so proud of the task force and their outcomes. We are just thrilled that they really dove in and saw the true challenges and are addressing those true challenges. Separate from our funding, there's the BPC Action Group. We did not fund that. We can't fund that. But they took the report that we funded to develop an action policy plan. And one of those parts in those plans was reimbursement and expansion of broadband, et cetera. You have the plans in front of you. COVID-19, the crisis, made those challenges actually and recommendations reality to change. And efforts by BPC could make these changes totally permanent. So I am just super excited again to hear what the task force has said, to hear the panelists, and this is something unheard of on the speed of what has been done. But thank you again for everybody in attendance. And I'd like to introduce Senator Bill Frisk to moderate and have some remarks. Thank you.
Good, thank you, Walter. And we'll jump right in. Since the beginning of the pandemic, city dwellers have gotten a taste of some of the problems that rural Americans face every day in accessing healthcare. Americans have moved as quickly as possible to seeing their healthcare clinicians through telehealth appointments. We've been thinking about telehealth for a long time in rural areas where people often need to travel long distances for doctor's appointments or for emergency care. And the problems have gotten worse in rural areas as hospitals have closed, as the hospitals have cut back on services and they furloughed or laid off employees. All that occurring even before the financial pressures of the pandemic hit. In my home state of Tennessee just last week, 29 rural hospitals just last week received rural readiness grants from the state to help with all of the immediate financial difficulties that they were experiencing and to ensure that they had continued operations through the COVID pandemic itself. rural areas in Tennessee have not seen a drastic uptick in unemployment like in many other cities, but statewide unemployment rates in April neared 15, 16%, an all-time high for the state. Now, Congress and the Trump administration responded to the pandemic by waiving Medicare restrictions for telehealth. They eased restrictions around where the service can be conducted and allowed telehealth for patients who were not already established with a clinician. There are also new flexibilities allowing payment for phone calls and text-based services. Congress has also temporarily allowed a patient's home to be an originating telehealth site. Adaptations to our current policies to allow healthcare at a distance has proved a crucial step in the overall response to COVID-19. But rural areas needed these flexibilities long before COVID and will continue to need them after the coronavirus threat is gone. Over the past year, as part of the Bipartisan Policy Center's Rural Health Task Force, I worked with other experts and stakeholders to determine the best path forward to address healthcare access challenges, specifically in rural America. We looked at payment, we looked at care delivery, the workforce, we looked at maternal care, and as well as the telehealth services to create a thorough set of policy recommendations to overcome legislative and regulatory barriers to rural healthcare. You know, all of the recent changes in telehealth regulation and law that I mentioned were recommendations put forward by this task force, but now they need to be made permanent. Today, we've convened policy and provider experts to discuss the current state of digital health and how rural areas may be able to move forward. The panelists. Alan Levine is Executive Chairman, President, and Chief Executive Officer of Ballad Health, an integrated healthcare system serving 29 counties of Northeast Tennessee, Southwest Virginia, Northwest North Carolina, and Southeast Kentucky. Dr. Jennifer McKay is an internist and medical information officer at Avera Health in Sioux Falls, South Dakota, and served on BPC's Rural Health Task Force with me over this past year. Jim Parker is Senior Advisor for Health Reform at HHS and is an integral part of the administration's push for rural health care in the United States. Prior to his tenure at HHS, he served as Chief Executive Officer of MDWise, Inc., an Indiana Medicaid managed care organization, and he served as co-chair of the Indiana University Health Population Health Management Services Organization. And Kripa Sripada is Health Policy Advisor to Senator Tina Smith of Minnesota and was involved in the discussions on policy changes for telehealth. So let's now jump right in. The coronavirus has given our country a taste of the problems that rural Americans face every day in trying to access health care. Alan, let's start with you. You're on the front lines in rural Tennessee and in Virginia, and you've created a new innovative health system model that is helping to preserve and grow rural care. Let's start right off with, why is it so much harder for people in rural areas to access care? And what has this meant for the population? Are there some unique tech capabilities or limitations? You know, you might even add what these limitations are for patients. But why is it so much harder for people in rural areas to access this care?
Well, Senator, first of all, thank you for allowing me to participate. It's always an honor to be on the same stage with you, even if it's virtual. First of all, you know, we serve a region the size of New Hampshire. And obviously, when you get into rural America, which really is about 90% of America's geography, there's a lot of distance between populations and where healthcare services tend to concentrate. And so obviously there's technical issues with broadband access. There's in terms of limitations in telemedicine. But the ability for people to get to routine physician visits or get to even, in some cases, emergency care is somewhat limited, particularly if you have big economic variation in terms of people's capacity to afford to be able to travel. And so there's a lot of real limitations. And of course, those are being made worse by the number of rural hospitals that have closed or that are projected to close over the next 5 years. And you're correct. That's why Ballad Health was created. And one of the big instigators for our merger that created Ballad Health, which is the only hospital system serving this region the size of New Hampshire, is the issue of technology. We may be the only health system in history that did a massive conversion of our technology platform in the middle of a global pandemic. We just went live this week on Epic in over 100 of our locations successfully, I'll add. So we're deeply committed to transforming ourselves to the use of technology so that we can create connectivity with healthcare consumers that's lasting and meaningful for them.
Dr. McKay, let's continue the discussion a bit. Your health system, Avera, is considered a real pioneer in rural telehealth. 15, 20 years ago, I remember visiting there and amazed at the great progress and how advanced you were. But there are so many challenges that have impeded widespread telehealth use. Tell us a little bit about the challenges that you've seen over the years and that you see today.
I think everyone is aware of the challenges related to just the technology and infrastructure. We've done a lot of work over the last 25 years to ensure that our broadband and our connectivity is in place. This has really been the work of our IT department in collaboration with the work of the Helmsley Trust that was the sort of the bedrock of the system that we built. As we've moved along, as we've grown to an organization that serves over 500 virtual clinical sites across 32 states, we've had to navigate a lot of other waters too. Licensing and credentialing is probably one of the biggest ones. But more importantly, I think what we've really struggled with is the idea of payment. The business model that we use is really more of a subscription-based services. But for rural health to really go into the future with this kind of technology, what we wonder is where the payment reform is going to come. And so now that we've had this nice regulation vacation, I think we are hopeful that the cat's now out of the bag and that we are able to continue doing this very good work, because it truly allowed us to turn up the volume on what we had already been doing. Within 24 hours of an anticipated surge, we were able to set up a call center that avoided 50 ED visits per day. This was staffed by physicians and nurses. We had a virtual command center that connected us all together. And then as we deployed our crisis sites, we even found a way to preserve PPE by using iPads in the ICU room so the physicians or nurses didn't always have to go in. So we're hopeful it'll stay. We know there are a lot of challenges, but we're really excited that in particular the work of the Bipartisan Policy Task Force were implemented very quickly because of what was required to combat COVID-19.
Thank you, Jim. Let's go to the administration. What the response has been, the approach to telehealth. I think all of us have been impressed, those of us who've worked on telehealth for years, at the response in terms of relieving a lot of the regulations and lifting those. And tell us what the overall approach and attitude to telehealth has been, and how this helps rural areas both now and in the future. And then what a lot of people are going to be interested in is the longer term thinking on telehealth. Everybody knows the positive response, but will these changes be made permanent? What are your thoughts? You probably can't answer that specifically, but what are your thoughts? And a little bit about the cost. I know there can be a concern that telehealth, if everybody uses it all the time, the cost of healthcare might increase instead of decrease. But comment a little bit on the administration's attitudes.
Certainly, I'm glad to, Senator. First, let me say that almost of necessity, the COVID-19 pandemic required the use of telehealth regardless of cost, because it was the best option we had to ensure that patients could access the care they needed while following social distancing guidelines. The administration immediately started eliminating policy barriers, working with Congress to ensure access to care through technology. Our experience this spring, in our view, has highlighted the telehealth rules and coverage policy vary widely between federal, state, and private payers, and between federal state and licensing board regulators. There was no simple switch the executive or legislative branch could flip to turn on telehealth across the board, but we did have the direct options within the administration of the Medicare program and also some within Medicaid in partnership with the states. Through the authority we exercised in the pandemic emergency declaration, we took some immediate steps to address some longstanding challenges in the Medicare statute relating to expanding eligibility for who could bill for these services. And that Congress also made a temporary change that allowed FQHCs and rural health clinics to bill for telehealth services for patients at remote sites like homes. These combined changes were important because many Medicaid and private insurers mirror or align with the Medicare payment structure. As a result of all this, we've seen a significant ramp up in the use of telehealth services. We think that's a very positive and was certainly critical during this time. These changes were particularly significant for rural areas because they opened the door for FQHCs and rural health clinics to provide telehealth services directly. They previously could only receive telehealth services from other providers. This has been a change long sought by many stakeholders, as you know. Looking forward, we do face the challenge of where we go from here. Consumer expectations are likely changed moving forward. We're going to need to look at the data and see what the logical next steps are and ensure a soft landing for telehealth instead of a hard stop, which we hope doesn't occur when the current public health emergency ends. That may include looking at what administrative levers we have within HHS. But there are also broader policy questions that you've mentioned that are statutory and would have to be addressed by Congress. As to whether telehealth increases costs or saves money, it's probably still an open question. The Congressional Budget Office has historically taken what some might consider a conservative view of this when it scores telehealth. If you look at the research, you see studies that look at generic cost avoidance or take more of an outcome focus. We've always known that telehealth is an efficient tool for rural health care by saving travel time and expense, as well as providing quicker access to care. However, travel time and expense are not covered Medicare expenses, so we may discover that the direct benefits to patients of telecare at home has increased the cost of care as a replacement for in-person care. While there may be additional quality of care savings from telehealth, the technology of telehealth has some cost, and we must determine if convenience for patients justifies that cost. The pandemic-driven increase in the use of telehealth may provide, however, more data to potentially get to clarity on this, which will be extremely helpful. As was mentioned, we also need to remember that relaxing reimbursement policies went a long way to enabling telehealth, but there are other issues to consider, such as licensure and the burden on clinicians who must be separately licensed in multiple states. And so I'll conclude with that, but lead by saying that we, as I mentioned, of necessity, found ourselves being very bullish and aggressive on expanding the use of telehealth services. I think we've, as Kripa mentioned earlier, the cat is out of the bag, so to speak, and we look forward to helping policymakers, congressional leaders, and regulators move the interests of telehealth and healthcare consumerism, particularly for rural areas, forward in a more permanent way.
Good, thank you, Jim. Kripa, let's turn to the United States Congress. That's sort of the administration where we are. We'll come back and talk a little bit about the federal response and how it interrelates with the state response. But let's go to the other branch of government, Congress. Does Congress share Jim's enthusiasm for growth, efficacy, effectiveness, and potentially long-term growth?
Yeah, well, thank you so much for the question, Senator. And before I start, I did want to let you all know, it seems like my building is doing fire alarm testing right now, so it might be the case that I have to mute myself, but so I apologize in advance for that. But I did want to say, just to start, certainly I think there is bipartisan interest in pursuing permanent telehealth changes. When my boss talks about this issue, she's thinking we really need to give people hope and thinking through how do we get through this pandemic, we have to think about how do we build back better. Excuse me.
We'll see what happens here and we'll adjust accordingly. Cripple, why don't we hold for a second, and if you have to leave, you can come back on. And let me jump. This congressional approach and attitude is absolutely critical. So let me come back to that. Alan, let me jump back to you. Or Cripple, do you want to continue now, or is your alarm going off still? You're on mute. You're on mute, Cripple.
We're still going off here, unfortunately.
Okay, good. All right, let's move. I'll come back to you. You can let me know, or you can take your iPhone with you and call from outside. Alan, let's jump back, because one of the barriers to expanding telehealth has always been the lack of coverage or adequate reimbursement. We have the privacy issue, and that sort of has been taken care of for the most part. The interstate commerce of going across state borders, that's gotten a lot better. But the reimbursement has always been a huge issue. And when I talk to physicians, they'd say, oh yeah, we'd like to do telemedicine, even though we weren't trained to do it and we don't fully understand, the technology, and I can't touch the patient and I'm not sure about it, but I'm willing to do it, but I can't get reimbursed for it. And I can't be on the telephone or on video all day long, taking me away from my bricks and mortar care. So where are we with reimbursement? How has it changed? And maybe even take a look into the crystal ball about reimbursement in the future.
Well, I think that's a great question, Senator. And going back to something Jim said a moment ago, it's possibly true that incrementally the cost in the aggregate of healthcare goes up incrementally with the expanded use of telemedicine. But if we're measuring cost based on that cost increase and the fact that people today are not accessing care that is needed, and we're seeking to save money by basically denying care that's needed, that's not really, in my view, that would not be the right way to measure cost, because there's a lot of cost there that's not perhaps being measured. And I think he was trying to say that, and I agree with him on that. But we certainly view cost to include the denying of services that are needed because of the downstream cost as a result, both in terms of socially and economically. I think the issue really is, and in our case, for the year that began July 1, which is our fiscal year, through the end of March, we had I'd say we probably had 2,400 telehealth visits. In the 2 months since April 1st, we've had 15,000 telehealth visits. A lot of that is because the reimbursement system, at least temporarily, engaged us. It's a big capital investment to get into telemedicine. And one of the things that we've advocated, and I think there's a lot of agreement on this, is at least on the front end, when the policymakers make decisions about how to reimburse, it makes sense for us to reimburse based on an equivalent cost of a personal visit, because that helps recover some of the initial capital investment. And then over time, you can determine what the cost differences are between telehealth versus a live visit. I think it's a lot more efficient. I think more people can be seen. We have one physician who wasn't doing any telemedicine before, and he shared with us, even now that they've reopened their practice, 70% of their visits are still telemedicine visits. And this is particularly impactful in Medicare, where you have a number of elderly people who are still going to be afraid to leave home for a period of time. The isolation they're experiencing by not being able to see a physician versus having the ability to see somebody through telemedicine, the emotional impact of that is huge. And I think that's where we ought to start, is how do you create the incentives for proper capitalization, and then getting the data to determine what the real cost variation is, and then reimburse in the future based on that. Seems to be the best model from where we sit.
Yeah, Dr. McKay, let me jump over to you just while we're on the topic of cost. And from a clinical standpoint, a clinician standpoint, clearly with the COVID during the pandemic, where clinics, elective surgery, everything was closed down, access was a big issue. And there's still this question, did people get sufficient care during the last 3 months? But the telemedicine from a clinical care standpoint traditionally has been if I have an sort of an urgent condition, and it might be an allergic reaction, it might be sinusitis, it might be a urinary tract infection, I could call into telemedicine, get it taken care of literally within 8 or 9 minutes, instead of in the middle of the night trying to find a doctor or find prescriptions and go drive 2 hours to a hospital and the like. Now we have chronic disease management coming in, but just comment a little bit on the quality of care that can be delivered through telemedicine, what we know, and Dr. McKay, y'all been at it for 30 years.
Yeah.
But just to sort of summarize for our listeners, because most of our conversation now is going to be about policy and cost and access, but just comment on the quality.
I would say that the quality is equivalent, if not in some ways better, and I'll tell you why better. As we were sitting here, actually got an alert that I need to take care of a patient in a distant site from me, and I kind of started subtly looking up information as we were going. And I know what I need to do and what conversation needs to happen with that local physician as soon as we get done with this call. The reality is that as a physician, working in telehealth has made me feel more like a physician than I have in a long, long time. And that idea that we are so dependent on the touch of our patients really comes to the forefront. And you're forced to do something that a lot of people complain about, and that's talk to your patient. So the connection, the personal nature of how this works, you get an undivided time with somebody who's important to you, important in your life, to be able to talk about really important health things. I had a wise attending back in medical school, as I'm sure you probably did, who had said to me, as long as you listen to your patients, they'll tell you exactly what's wrong with them. That has not failed us, but the other benefits that we see from the standpoint of rural health in particular is the way it elevates the team and the boots on the ground on the people who do touch those patients. So, for example, in our emergency services, we do a process where we can actually intubate over a camera. You would have never thought that possible many years ago, and you, as a cardiothoracic surgeon, certainly know the difficulty and the risk in doing those types of procedures. But we knew with COVID and the exposure to those people on the ground that we had to come up with some pretty good protocols to support the group. It's well known in high reliability organizations in the world of patient safety that if you don't do things very frequently, it's much more difficult. So we're able to support the boots on the ground. We're able to spend more time with patients. And I would say absolutely from our perspective, telemedicine prevented a surge. So I know Walter Panzier and the Helmsley Trust didn't set out to stop a pandemic in South Dakota, but they certainly did with the work that they're doing. And I would just say, don't be afraid of it. You had the benefit of being a student of the Dr. DeBakey's of the world. Well, we don't necessarily have Dr. DeBakey's anymore. And part of it is because of the regulation that surrounds using new technologies and developing new things. We certainly understand why that's the case. But telemedicine is a well-known capitalization of technology that everybody uses every day. And what gets in the way of it is all of the things surrounding it in terms of payment, in terms of regulation for security. And so my challenge to people really is to let the creative minds of the physicians in the United States work and use this as a clinical tool. We know the heart and soul and the spirit of physicians can be unleashed with this kind of thing, and I think that's certainly the case at Avera. So if you're looking for proof that medicine works or telemedicine works, we'll tell you. We've got a lot of data.
Yeah, thank you. And I think that's really important for our listeners as we talk about policy, health, and well-being. And I should mention that I'm on the board of Teledoc and have been for a long time. And we will probably see 15 million people, doctor-patient interactions with board certified physicians actually historically in the state that somebody had been. And when you look at quality, you look at cost of those interactions, whether it's RAND or numerous study has showed that quality is equal and from a cost standpoint, huge cost savings for that type of care. And that's not really chronic disease management, but that type of care because you prevent emergency room visits. So let's come back to Kripa, and you're safe and sound there. And talk a little bit about Congress, because that is the branch of government that ultimately dollars and cents arise with, and legislation, because a lot of these release and regulations may require regulation both at the federal and the state level. But give us that congressional view.
Yeah, definitely. And apologies for the interruption. But as I was mentioning before, I think there certainly is bipartisan interest in permanent telehealth changes. And as my boss is thinking and speaking with rural health providers in particular, how we're going to get through this pandemic, we have to think about what is something that can give us hope. And I think creating these permanent telehealth fixes is part of that solution. I think as we're examining how, providers have changed so quickly and shifted so quickly over to telehealth due to this pandemic, it's a unique opportunity to study what's working and what we should make permanent. So, asking questions like, are temporary flexibilities working effectively and can they be made permanent? Certainly, I'm hearing a lot from providers about their gratitude for some of the regulatory changes that you mentioned, Jim. Certainly there's continues to be a need for other fixes like increased reimbursement in the ERISA market and some changes for reimbursement parity for community health centers and rural health clinics. But, building off of what we're seeing now and how it's effective and what should stay permanent. The other thing is, and I think you had mentioned this earlier, is we're seeing a huge uptake in the use of telehealth services. And what we need to study along with that is, are patients and providers also preferring this as a first step for a visit? And if they are, should we be prioritizing that as the first line? And then I think the other questions we want to answer are which services should we be providing that are audio only versus those that require video, which are most effective in which modality? And then what is the infrastructure that we need in place in terms of broadband, but also the funding for special equipment that I think has been raised several times during this conversation. So I think there certainly is bipartisan interest, and now we have this opportunity to really examine what's going on and what are the data showing us and what we should implement from a congressional standpoint.
Yeah, I think both you and Jim have pointed out the importance of data and data collection and the assimilation of that data and analysis of that data, because there's a huge amount of data from the last 3 months, and getting that data and analyzing it can give us a great platform because of the volume of calls that have come in. And I think you bring up, Kripa, and everybody has, we talk about it, we probably should be talking about virtual health and sort of telemedicine, but remember, telemedicine can mean just a cell phone, voice, which you talked about. It can mean video, which we're using now, that has to be privacy protected and which has been historically and it can be. And it can also mean text messaging, anything kind of virtual health. And policymakers at the state level and at the federal level are going to have to decide. And it's tough as a policymaker because you don't want just things to go haywire and out of control with everybody on the telephone getting reimbursed exorbitant sum. And that's the challenge the policymakers have. Us, and Jim, let me turn back to you. I spent probably at least two and a half of months during the pandemic, I should say very productively, because I was able to use technology, but I was in rural Southwest Virginia. And we just got cell coverage there really about 2 years ago. And the cell coverage there is spotty, but have no internet coverage there. And I was probably an hour from the nearest hospital, and the nearest town was 30 minutes down the mountain. And that was a town of 150 people. And I'd have to go to that town every day just to be able to have sort of internet access. I say all that because this whole access to the internet, which is to me, one of the major social determinants that the pandemic brought to light, is a huge issue. Payment for Medicare paid for the voice calls recently. So give us your vision on how much flexibility is going to be necessary in terms of payment and video and voice as we look ahead. And then you also might comment on, I'd be interested in others as well, on what this country can do for both telemedicine, telehealth, in terms of internet access and education as we move to hybrid education. But Jim, take it from there.
Sure, glad to. And as you mentioned, telehealth, particularly, broadly applied across the country, can't be successful without the technology infrastructure to support it. And through the work that we've done and through how we've been informed by the leadership that the BPC has taken on these issues, it's clear to us that we could develop a magnificent reimbursement policy for telehealth and have it stall if the technology is not there to support it. And so in that regard, we've been doing quite a bit of work recently in partnership with other parts of the government, because we know that certainly how we approach reimbursement for telehealth is important. We can either be the grease that helps the wheel go, or we can be the impediment. But even if we get reimbursement right, it's important that nationally we've got the technology infrastructure to support it. So we're doing quite a bit of work currently with our partners, both at the FCC, which I know is separately making significant investments across rural America in technology infrastructure, wireless infrastructure, as well as with our partners at the Department of Agriculture, which have the ability to provide funding to so much of rural America. So hopefully we'll have more to say on that in the near future, but we approach this very broadly and know that our actions alone won't be sufficient to bring this to life.
Yeah, and I think that's really important. The sort of Fed administrative executive branch interaction with Congress is important, and also the state and Fed interaction, especially when you come to things like infrastructure, in addition to reimbursement. Kripa, do you want to add anything to that, either on the broadband access or the amount of flexibility that's going to be required in the future? And Kripa, you're on. Yeah, there you go.
Yeah, I think, definitely, I think there's interest from Congress in making sure that we're supporting the rural broadband infrastructure. And we're grateful to some of the work and commitments that the FCC has made on that front. And I think, it's an interesting question about, how much flexibility is needed. And what has been interesting about seeing this rollout is we've heard from rural areas about the need for audio only services to be reimbursed because they don't have the broadband infrastructure in place to have a video visit. So then if that's the case, is it really better to have an audio only visit, or should we be thinking about, we need to make sure that we're deploying our broadband infrastructure to these parts. And then we also really need to be, really intentional with how we think about what audio only services works for. So we're hearing it could be helpful for behavioral health services and therapy. But, on the other end, for a neurologist who's trying to make a diagnosis, it might be really difficult to do that through an audio only option versus being able to see someone face to face and how they move. So I think these are all really important open questions, and I'm heartened by commitment from Congress and from the administration to think, really intentionally about all of this.
I think one of the things that surprised me as a physician, and I wasn't trained this way, and most physicians are not, is that you don't have to, for most, the 1.4 billion visits out there between doctors and physicians, for most, you don't have to be in the room with them to examine them, put a stethoscope on. Technology can do so much. The other thing that surprised me is that you don't need to have video for most of the common urgent things you go to the emergency room for. You would think you'd have to have video as well as audio, but you really don't. And for some of the telemedicine companies in the past, as many as 80% of the phone calls, contacts that are done could be satisfactorily done, as much as 80, maybe even 90%, by just telephone, by just voice. And so when you've got to sort that out, and from the policymaker standpoint, it's hard, because how do you reimburse? How do you know which is effective or not? But it's interesting coming in. Dr. McKay, again, coming back to the field, because you're out there every day and you have this long-standing experience. What changes in telehealth are you seeing in rural areas as a result of the more recent pandemic-related legislative and regulatory changes? And talk to us a little bit about providers, how they bill for telehealth and the like.
We're still really working that out. What we do know is that that we have had to put some muscle behind understanding the business proposition for telehealth on a go-forward basis. So we had to really look deeply at the lifted restrictions and say, okay, what can we do? Will it be on parity with what we could make for an in-person visit? But I think where we've actually seen the most growth, and this is really exciting, is truly in the home care front. In our organization, we actually have taken care of many more COVID patients in their homes than we did in either our hospitals or even our clinics. And so those devices for home monitoring, I think, are becoming more important. But I want to just highlight that what telemedicine is bringing up the conversation is a lot of unseen work that physicians and nurses have done for years, and without credit, without anything. So I think those are important pieces that as we've gotten better at treating those acute illnesses, that we've moved into more of this chronic disease management. And that's where these ongoing conversations have really had to come forward. So we're hopeful that there can be a business value to this. We know certainly that from the prevention of expensive hospitalizations, that it's absolutely impacted it. But we also know for our elderly patients, there could go a long way toward preventing nursing home admissions and the like. So I think there's a lot of wins out there. At the end of the day, I think what rests on your shoulders and of our public advocates is to really recognize that this work is being done, and without some major change in the business proposition, that this will be hard to make a go of it. And physicians have a very big desire to use this technology.
Good, thank you. I want to go. We have so many questions and coming in. It's a fascinating discussion and appreciate it. We can turn to audience Q&A, which I think I'm going to do now because we have about 15 minutes. And if you haven't done so already, you can open that Q&A box at the bottom of your screen to submit your questions. And if we'll have hundreds of questions, won't be able to take them all, but we'll take selected ones now and get back with you on the others. So let me go to the audience, and Jeff Selberg, and I'll just repeat the questions to save time. Is telemedicine or digital health grows, will healthcare providers reduce their office and clinical space that no longer will be needed as a way to reduce cost, as opposed to running parallel systems? Alan, why don't I open that with you?
Yeah, the answer to that would be yes. I mean, I think as needs shift, and this actually touches on a bigger issue of cost. And in rural areas and non-urban areas, in our system, for example, we subsidize over $150 million a year in physician practices. As physicians become more efficient, because whether it's because of space needs or their time, that reduces, frankly, the cost of some of those subsidies, which actually can help some of these rural hospitals that are currently losing money subsidizing all these physician practices. There's a lot of different things that will happen as a result. Anytime payment policy changes, there's going to be a cascade effect. I definitely think if a physician practice becomes more efficient and as much space is not needed, you'll definitely see health systems and physicians themselves try to reduce their cost overhead, which I don't think is a bad thing unless you're in the real estate business.
Yeah, I think, based on our experience, and as I mentioned, I'm on the board of Teledoc, a lot of physicians will use just hybrid care. They're going to continue to have their bricks and mortar practices, but between appointments or canceled appointments, they'll be able to actually access telemedicine in a very efficient way that they hadn't been in the past. I don't see any big change coming early on, but clearly the more you can do virtually, and some primary care practices will be purely virtual in the future, where you don't need bricks and mortar, that you could send people to the home to do the blood test or the diagnosis as we move care to the home. So it'll be interesting to follow. Let me go back to the audience, and Dr. McKay or Kripa, you can take this one from Steve R. Can you talk about the impact and challenges of allowing physicians with a license in one state to practice across state lines or in another state? What are the licensing concerns? And let me just say, as early as 3 years ago, there were state regulations that were discouraged, almost shut down telemedicine in a state. And this was by a lot of physician groups who just weren't getting reimbursed for it and said, we don't want virtual healthcare. That has changed, but still up until COVID, you would have to have a licensed doctor licensed in a state to be able to give virtual care in that state. Those regulations were lifted recently. So, Kripa, Dr. McKay, why don't you answer the question about the challenges of allowing physicians across state to participate?
I'll start. I think the initial challenge really is just the amount of paperwork and the small differences that exist between states in terms of licensing that can really be somewhat of a hurdle. And it might be something as simple as number of continuing medical education hours. Beyond that, there's an additional layer that we don't often talk about, and that's the hospital-based credentialing process that happens. That's an additional piece of that. So while the states have been able to form and to collaborate into these medical compacts, that's where I get many of my licenses, is through the Interstate Medical Licensing Compact. Our organization actually has to have a whole department just for physician credentialing on top of it. So it adds a lot of cost. Certainly there is a balance. We know why licensing and credentialing is important. We know that we have to keep a peer review process strictly in place for our profession. And so I think it's an ongoing discussion. The good news is that we're making progress, and I think technology has really forced that issue.
Great. Kripa, anything to add?
No, I think that's exactly right. I think from our perspective, we were hearing a lot about this issue of providers from bordering states, so South Dakota, North Dakota, trying to provide services for people in Minnesota, and these restrictions were in place. And it seems like it's such common sense to allow them to happen, especially during a pandemic, but why not longer term as well?
Good, thank you. Let me go to Melinda. COVID-19 has prompted changes to regulations on controlled substance prescribing and release of personal health information, specifically regarding mental health. Both of these changes have improved access to treatment for substance use disorder and mental health care via telehealth. Comments? Again, Dr. McKay, why don't you just take that one?
We have a long history of providing support for mental health across our state. I think last summer we put a farmers hotline in place for this particular purpose. We know what a risk it is. We know how much of a shortage there is, and quite frankly, it's one of our highest demand areas of specialty. So we think these are good changes. Of course, the people that are the purveyors of the service line of our behavioral health really want to put patient privacy in the forefront, and we know how important it is. Again, it all comes back to a balance. Sometimes I think with these regulations, small changes can make it easier to do the right thing. So you don't have to throw the baby out with the proverbial bathwater. You can simply have a discussion about what are the barriers. So we are well in a position, I think, from our organization to continue and facilitate those discussions. And of course, we've had the support of our congressional contingent here in South Dakota advocating for that on a national level as well.
Thank you. On the technology and how tech savvy you have to be, and I have a question from Aaron that I'll come to. And let me read the question, then I'll comment, and then I'd like to hear from the other panelists. From Ann Erickson, what do we do about seniors who may not be tech savvy or may not have devices and data packages to effectively move to telehealth? And it's a gretic question. Is telehealth really virtual health just for younger people? And I think our experience at Teledoc has been to know that the usage for seniors has been equal to that to younger people. Younger people are probably using text messaging as their telemedicine, virtual health, especially for behavioral health more. But in terms of access to video and voice, we've seen a huge penetration in the senior population. But clearly, there are seniors who are not going to want to boot up a computer and go through the activity. So let me open it to the panelists. And do you see the seniors having an important barrier that needs to be addressed in some independent way? And Dr. McKay, I hate to keep wearing you out, but I know you're on the front line there of this, who's using telemedicine actually, but comment on seniors' use of technology.
Well, when you're an internist, you have a special heart for our older patients. So I'll tell you a couple of stories. One is our older patients still pick up the telephone, and that's an important piece of technology for them. But number two, whether or not these individuals have technology, many of them use it because they have grandchildren and they learned how to FaceTime and the like. So, for example, my mother-in-law, we've given the term gramoji. My daughter taught her how to send emojis, and so she'll send a lot of them at one time. So she's actually quite tech savvy. It's taken a long time, but that family-based connection to me is where the win is. So although maybe my mother-in-law would prefer a phone call, at the end of the day, it's available to her, the technology, simply because she wants to stay in contact with her family. So I think it's a win, because we cannot expect to honor and care for our older patients and our elderly seasoned citizens without the support of all of our families. So I think it's a win all around. And I agree with you. I think it's a lot more common than anybody knows.
Dr. Frisk, may I?
Yep,
May
jump
I
in.
offer? Yeah, I think I think you have to unpackage this. There's two parts to this question. It's an important one. Number one is the senior population today and steps that can be taken to work with them so that they gain comfort with it. I think that's important, as Dr. McKay was just saying. But keep in mind that over the next 20 years, as people age in to retirement age, the population that's going to emerge is going to be a population that's going to expect this. And so we're going there. The market's going to be demanding it one way or the other. And the question is what's the pathway there? And you have to start somewhere. So you start by identifying the current population. And we've learned through various mechanisms, whether it's population health, managing diabetes, we have medical homes. We have a way of working with our patients to get them comfortable with the use of technology. Holter monitors. Remember, we used to have everybody on Holter monitors, or now, they're capable of learning it. And I think so. It's really a two-part issue. One is what you do with the population today, and second is how do we prepare the marketplace for what the marketplace is going to be demanding, whether we want it to or not.
Good. Very, very well said. Very well said. Kripa, we may have covered this, but from John B. from out over in East Tennessee, what about broadband coverage? Some policymakers have encouraged increased funding for rural health broadband, expanding this to all health professional shortage areas, including urban areas. Do you think rural areas will still see some of this increased funding?
I think it's a really good question. And I think, as we had mentioned before, there's certainly bipartisan interest in Congress and in the administration to make sure we're getting broadband where it needs to be. And I think when my boss is thinking about this issue, the goal is really to make sure that communities that don't have reliable internet access are able to get it. And I think just a good example to provide is that Minnesota has one of the largest urban native populations in the country. And it's a community that relies on schools or libraries in order to access internet. And so as libraries have been closing, the elders of this community have not been able to go access internet in these common spaces. And so it's exposing these real urban connectivity issues that are impacting people's health. So I think that the answer there is, we can't do this overnight. And it's really important that Congress works with the administration and the relevant agencies to make sure that the dollars are getting spent and being sent where they should be.
Yeah, Jim, any comments on that?
I think I would agree with Kripa. We're very interested in seeing funding for the expansion of broadband capabilities continue. I'm hopeful that the experience that individuals have had with telehealth and remote health capabilities will resonate with their elected representatives, and that we can continue to push this forward.
Good. The area of mental health, which has really been interesting. If you look at telehealth, virtual health, telemedicine, of the existing infrastructures out there, and this is amazing to me, the fastest growing dimension by far is mental health. I think we're going to see an expansion from traditional telemedicine. Of the 1.4 billion visits out there, less than 1% could be considered telemedicine before the pandemic. As we all know, it escalated to 80% of all visits, and where it'll settle out will be somewhere in between. But what's really exploded both before and during and will continue is mental health. And we don't know if it's the technology that people, have the anonymity sometimes of being just on voice, but all the data shows that the quality is equal to and maybe better using technology for mental health. And so I turn to the question from Gary Claxton over at the Kaiser Family Foundation bringing this up. I've recently been in some conversations with employers who have pointed out how important telehealth has been for connecting their employees to mental health care during this period. He continues, the inadequacy of provider networks for mental health is also an important topic. Can virtual health help with the network inadequacy issues? I think really important points coming in. Let's kind of go around and hear, I guess, from our two people who are really out front on this, and from Alan and then Dr. McKay. Mental health, adequacy of providers, experience today. Alan?
Well, I think telemedicine, or the access to technology, again, in a region the size of New Hampshire, where the majority of our region and the majority of America, 80 to 90% of America is rural. And, the reality is people, particularly children, that go without access, it develops into something much worse and much more severe. We're currently in over 100 schools with teletechnology, where instead of parents having to leave work to bring their kids to the doctor, we can see the kids right there in school. And it's been very successful. And there's no reason that can't be used to help assess children who are in crisis. Right now in schools, teachers are being expected to manage teenagers in crisis. And then they have no one to hand that child off to because of the lack of access in many of these rural communities. But by deploying technology, we now have all the tools in place to have a centralized mechanism for assessment, and then making sure we identify those children that are in crisis and getting them the help they need. I see no reason why anything should inhibit the rapid expansion as much as possible into mental health and behavioral health. And I think it's frankly a crisis right now. And if we could have as much, I think if we can make this as much of a priority as some of the other things we're prioritizing, I think rural America will be well served.
Yeah, Dr. McKay?
When you're from a small town, it's easy to kind of get in everybody's business. So I think the additional value, aside from what Alan has commented on, is just the privacy. In South Dakota, we have very small towns, and people would see your car sitting at the therapist's office. So the amount of privacy that it offers, I think, really adds to the removal of stigma for seeking out these kinds of services, and it's something that we've proved over and over again. I think the other piece I would add in terms of the school aspect is a lot of the mental health support that happens in the schools also deals with learning disabilities, and those kids are very high risk long term. So I think it's a perfect place to build on it and to help it grow.
Okay, thank you. Bill, I'm going to flip it back to you. Unfortunately, we've come out of time. We covered a lot of topics and really appreciate, we've had over 900 people be on this call today, and believe it's been informative. I know people have a lot more questions, but to me, it's been a real honor to be with this panel. I want to thank each of the panel members. Bill, let me pitch it back to you. Thank you all. Bill, you're on mute, Bill.
This. Sorry about that again. Thank you again, Senator Friss, Dr. McKay, Alan, Crippa, Jim. This has been a very informative discussion. I appreciate you taking the time, sharing with us your experience and your background in all this area. Thank you all for those who have participated and called in on this video. I'm sorry that we weren't able to get to all of your questions. I am very happy that BPC has launched this effort a few years ago. I come from a rural area. This is very important to me. Jim, I am from Indiana, so I appreciate the issues that you have had to focus on out there. One last thing I want to point out is that Just recently, the bipartisan policies building upon the last comments that the senator made about behavioral health. We recently launched a major task force also focusing on the integration of behavioral health and physical health. And that's being co-chaired by former Congressman Patrick Kennedy and former Senator John Sununu. So we're going to continue to work in this area. It's important for us. It's important going forward. Thank you all for taking the time. Thank you all participants who have called in. Have a good day. Stay safe. Stay healthy. Thank you.
For election directors to hold office